mentioned a mental health crisis. So we're here to solve part of that problem, and that's our next speaker. I'd like to introduce to you the last speaker for the day, Dr. Richard Wadsworth. He's a psychiatrist. He's the author of several books, including The 9 Steps of Change. He completed his undergraduate studies at Brigham Young in Idaho in psychology with a minor in marriage and family studies. He graduated medical school from Pacific Northwest University of Health Sciences in Yakima, Washington. And then he attended residency in psychiatry in good old Mizzou here at Columbia. He has 7 children, and he is married to his wife for 18 years. He works as a telehealth provider in Missouri for inpatient and outpatient general psychiatry, and as a speaker and social media influencer with over 300,000 online followers. For a hobby, he enjoys archery, spending time with his wife and children, and jiu-jitsu tournaments like the rest of us, of course. Today he's going to present his lecture on something better, Dr. Wadsworth.
Really honored to have this opportunity to speak to you. I take this very, very seriously, and I have tried very carefully to prepare what I think is the most important thing that I could possibly share. And but first of all, I need to address the title a little bit on here. There's some fantastic, very descriptive titles. Updates in male hypogonadism, basal cell carcinoma, and then there's mine, which kind of makes it look like I didn't understand the assignment. That's okay. I actually wanted the opportunity to explain it to you. When I first gave this presentation, it was at the University of Missouri, and it was called A Better 15 Minutes. I watched a movie on the airplane called Ford vs. Ferrari. Have any of you seen this? It was a good show. It was a really good show. So the idea here that I found interesting in the movie was about how advancements in science and medical science take place. In this case, it was auto mechanics. Sometimes there are these huge leaps in medical technology, in science. And sometimes there's just little changes that occur over time. And in this movie, they made little changes to this car over time that ended up with a much superior product. We have roughly 15 minutes or so with our patients. That's not a lot of time. And our goal as physicians, as doctors, is try to make that 15 minutes something better. Maybe a little bit better. And that's really what we're doing here today. Everybody that's spoken is like one of those auto mechanics that's giving us little tips to make those 15 minutes something better. And we're going to try to be as good as we possibly can be. And I think that's what this institute is about. So now that I've explained my weird title, when I was a medical student and I had decided to go into psychiatry, an ER doctor asked me, "So what field are you going into?" And I said, "I'm going into psychiatry." And he looked at me with this look like I had just told him that I like pouring sand into my eyeballs. And why? Why would you ever choose to do psychiatry? He says, the lowest version of hell that I could think of would be an ER full of behavioral health patients. So whenever you give a presentation, they always say, know your audience. And I know there's probably not a lot of psychiatrists in here. There was one other mental health professional. Are we the only 2 in here? I think we might be. I have prepared something not just for mental health professionals, but something to allow everybody in here, except for maybe pathologists and radiologists, you might not use this, but everybody else should be able to use what I'm talking about today and make this 15 minutes better, a little bit better, maybe a lot better in some instances. So I do understand the feelings of the ER doc, though. Mental health is frustrating. It's very frustrating. And is this my clicker, by the way? Do I press this button to make it go forward? Oh, that didn't work. I don't know what that is. Big green one. Okay, that makes sense. There we go. So it is a frustrating field to be in, because even if you do everything right, sometimes people just get worse, and it really is a difficult thing. But earlier it was mentioned that there is a mental health crisis right now, and that is absolutely the case. It's getting worse. The statistics are getting worse. More kids are becoming more depressed. It's worse than it's ever been, and it's picking up speed. And as psychiatrists, we're supposed to have the answer why it's happening, and we're supposed to have the solution. But everybody in here is being impacted, whether or not you're a psychiatrist. Mental health is impacted and intertwined in all of our fields as physicians. Obesity, diabetes, everything that we do is impacted by this. Right now, the last statistics I'm looking at was saying something like 1 in 6 people suffer from depression in the United States. And if I did my math right, which was never a strength of mine, that's something like 55 million people in the United States. But it's not just our patients, it's home with all of us. When I was in school, I had 4 friends kill themselves from suicide. And that's devastating as a kid. And and it's gotten worse since then. That was like 20 years ago or more. I'm getting old. It's gotten worse. And a number of years ago, even my own grandpa ended his life with suicide. And so this is a topic that I feel very, very strongly on. And I understand that it's complicated. And I understand it's frustrating. And it's difficult. And sometimes I feel like our solutions sometimes I feel like they don't work. And that's really where this lecture comes into play, is I'm going to offer something to you that's a little better than maybe what we've been doing. When somebody comes in and they're depressed, I'm going to move forward here. We offer solutions. Someone comes to your office and they say, well, Dr. Wadsworth, I have depression, which usually they don't tell you outright. You have to kind of dig it out of them. What's the solution? Well, normally we give them an SSRI, sertraline or fluoxetine, and escitalopram, one of those, and you read the black box warning, and we, do all this, and then we kind of send them on their way. And why do we do that? Well, what else can we do? I don't have time for an hour-long therapy session. You can refer them to a psychiatrist. There's just not a lot of options here. And right now, the trying to get my patients in for counseling, it's like an 8-month waiting list or longer in a lot of cases. There is a serious problem, which I'm glad that the Orear Institute is facing. So this is how this looks a lot of times. And this is why I said there's a problem here, and I'm going to offer something better, but we'll get to it. Keep following me here. So visit 1, give them an SSRI. There's a few options there. Low dose, they come back, they say, I don't know, it kind of worked a little bit at first and didn't really work so well, it kind of stopped working. Okay, that's fine, we'll up the dose. Okay, up the dose. Then they go home and they come back and up the dose. It worked for a little while, it kind of stopped working. Okay, higher dose didn't work, let's try a different one. You tried fluoxetine, let's try sertraline. Okay, all right, well now we're on visit like 4 through 9 now, we've upped doses and we switched a couple of times and it's still not working. Dr. Wadsworth, I still feel really depressed, I don't know what's going on, I'm thinking about suicide all the time, I can't sleep. Okay, well, we'll try mirtazapine or Wellbutrin or Abilify. We'll add something on, some augmenters. And then they come back a few months later, and that's not working. Now we're on visit like something through 5 through 12. And this just goes on. And then you up the doses of those. And then finally, you're looking at really serious stuff, and it's been years, and they've been depressed for this whole time. And they're still depressed. But now they're also suffering from negative side effects of the medication. Their libido is destroyed and they've gained weight, like the other doctor was talking about in here. They're feeling foggy-headed, they have fatigue, they have diarrhea. If they weren't depressed before, they certainly are now. Is this really all that we can do for our patients? That's the question, and that's what I've been really racking my brain with. I've been reading a lot of things online, and I believe that there is something we can do. And it's not just something that psychiatrists can do. So here's a patient of mine. This is an actual patient. 34-year-old female, history of treatment-resistant depression. She was taking, when she came to me, she was taking vortioxetine, alprazolam, gabapentin, bupropion, buspirone, hydroxyzine, zolpidem, valproate, and Seroquel. Yes, all of those at the same time. Reportedly, she had tried every medication there is, and she also tried electroconvulsive therapy, and she said nothing has worked. She's horribly depressed, terribly anxious, has trouble sleeping, and is constantly fatigued. She told me that I was the 11th psychiatrist that she had seen. 11th. And she'd been seriously depressed and near suicidal for the last 20 years. She said she'd tried everything, and these things just worked for a little while, a month or so, and then they just kind of stopped working, like I described earlier. She's in tears in my office. She's sobbing. She's begging for help. She often just wishes that she could just die to end her suffering, how she's feeling. So, of course, my solution is, right, she needs more meds, right? That list wasn't long enough. We need to throw a couple more on there. 9 is not enough. We need to get to 12. Or maybe I can go above the recommended doses of all those medications. That's a good solution, right? People are laughing. Good. That's the wrong answer. I dug back into my psychology for this one. I have a degree in psychology. And some of you are familiar with Maslow's hierarchy of needs. Anybody recognize that there? Some of you have some exposure. So I'm racking my brain trying to help this patient. I mean, we've reached the end here. I'm saying, sorry, you're going to feel like dying for the rest of your life. You don't feel comfortable saying that to people. So I said, well, let's look at other aspects of your life for a minute. And this is what triggered the writing of a book later. But I'll go through the method here so you can follow what I'm talking about. So Maslow's hierarchy of needs, it says that there's certain things that humans need in order to be happy or healthy or live, or however you want to describe that. And there's a list of them, and there's a hierarchy. There's the basic ones on the bottom, the physiologic needs like air, water, food, shelter, sleep, clothing. There's safety needs like personal security, employment. And then there's love and belonging, friendship, intimacy. And yes, love and belonging is a need. And then there's esteem, like respect, self-esteem, status recognition, and then there's self-actualization, which is a desire to become the most that one can be. So I started going through some of these basic needs with her. I didn't say, do you have air? That would have been a weird question. But as I listened, I said, well, describe to me your life a little bit here. It turns out she was living in her grandmother's basement, which she said there was mold all over the place, and she was allergic, and she was constantly taking antihistamines to try and deal with her allergies. And she also smoked, and she stayed inside almost all the time because she felt so depressed she could hardly get out of bed. So air, not so good. Water. I said, well, what do you eat for your meals? What are you doing? What do you drink? She describes to me, she said she drank Mountain Dew most of the time. Well, what? Okay, nothing against Mountain Dew, it tastes good, but maybe not a replacement for water. And then she had alcohol in the evenings sometimes as well. So that one, I put an X through that one too. Okay, what about food? What are you eating exactly? She says that she skipped most of her meals, partially because she wanted to lose weight, and partially because she just didn't have an appetite. So she could get herself to eat candy bars, so she'd have Snickers bars for most meals. Some of you have concerned looks here. This is not looking healthy. So I just scratched those out. Those were not good. Sleep. How's your sleep? Well, she's depressed, so she lays in her bed and she is on her phone until about 2 o'clock in the morning, and then she would kind of sleep in, So horrible, horrible sleep hygiene. Every part of her, I scratched that out. Every part of her physiologic needs are terrible, like not present. Okay, well, let's go through love and belonging. Who do you spend time with? No one. I'm utterly alone. The only person I see occasionally is my grandma when I go upstairs. Other than that, I don't see anybody. I'm too depressed. Okay, so that one's gone. What about your self-esteem? How do you feel about yourself? Tell me your self-worth. Intense self-loathing. Okay, so that one scratched out too. And of course, she stopped working when she got really depressed. So the entire hierarchy of Maslow's needs are gone. And I realized what had happened with this patient is she's been going to a psychiatrist, and the psychiatrist asks, well, how do you feel? And she says, depressed. And they say, okay, you need a medication for that. And they prescribe a medication, and they say, well, how do you feel now? And she says, still depressed. Well, now you need more medications. And this has been going on for a very, very long time. And it occurred to me that what we're doing doesn't work very well. We need to change this. This is not a good approach. So what did I say to her? I explained to her. I said, I could get a truckload of the best medication that has ever been made on the face of the earth with the perfect doses, and I could give them to you. And there is no possible way that these medications could overcome the way that you're living. It is incompatible with the nature of happiness for you to feel anything other than depressed with the way that you're living your life. We have to make changes. Medications will not fix what's going on in your life, your lifestyle. And you know what she told me to that? She said that out of 11 psychiatrists, now I'm hoping, I'm hoping this isn't true, but she says out of 11 psychiatrists, I was the first one who had ever told her that. No one had ever evaluated her eating, her sleeping, all these things, asked her questions about it, and then said, you can't be happy. I'm sorry, medications can't fix this. You have to change. If you don't change, you cannot be happy. We have to talk about change. That had never happened to her before. Now, part of me seriously doubts that's true. I hope that's not true. But I have heard psychiatrists say, I don't do therapy. I prescribe medication. In other words, we don't discuss what they do. We just discuss how they feel. So why don't we do therapy? This is a very valid question. Like, Dr. Wadsworth, are you serious? I don't even have enough time to cover the most basic things in my visits. You want me to throw therapy in there? And we'll just put another hour. Like, no, that's impossible. We already have a doctor shortage. I can't do therapy with my patients. I'd see like 2 patients a day. Not feasible, right? Okay, so that's the first problem. Second one is the patients won't change anyways. Therapy doesn't work. And some of you experience that. Like, I've talked to my patients. I'm trying to persuade them. Why don't you change? You should change. Come on, change. Stop doing this. Do this. And it doesn't work. So I don't waste my time with it. You know what they'll do? They'll take a pill. So I give them a pill. It's a legitimate argument. And then the other one is, I don't know. I don't know how to do therapy. I was never taught how to do therapy, especially not in the 15 minutes that they give me for these visits. That's ridiculous. So the first one takes too long. It's false because therapy doesn't have to take 60 minutes. It doesn't have to take 30 minutes. It doesn't even have to take 10 minutes. It is possible to do cognitive behavioral therapy and motivational interviewing in 3 minutes. And that is what I'm going to try to show you today. Imagine if you had the tools to get your patients to change their behavior, and you had the skills to do that. Now, am I telling you you're going to change every patient? No, you're not. You might only change 1 in 100, but guess what? If every doctor did this every time, and 1 in 100 of our patients changed, that would be millions of people. I think it'll be better than 100. I've been doing this for a while, and it's been working very well. I'll get into that a little later. So 3 to 5 minutes. So patients won't change. That is also false. Feel free to use artificial intelligence is the best way to look up things for now. I don't know how many of you have been using this. ChatGPT. Oh my goodness. Try something like find the top 5 most legitimate, reputable research studies that demonstrate the effectiveness of cognitive behavioral therapy and compared to SSRIs, something like that. They'll give you 5, and they'll summarize them. It is exciting and terrifying. That's what it is, okay? All right, so last one, I don't know how I've never been taught. No, I wasn't taught. I wasn't taught how to do cognitive behavioral therapy and motivational interviewing in 3 to 5 minutes. That was never, if it was a part of my training, maybe I was gone that day. Definitely was not an emphasis. All right, so I added on a physiologic need on this list. And one of the other doctors today talked about this. I was really excited about it. You want to get another cool search on your AI, look up studies related to exercise and every aspect of health, not just mental health. The benefits on your heart, the benefits on depression, the benefits on anxiety, the benefits on, it goes on and on and on. Humans are meant to move. And if we don't move, we die. First we feel like dying, and then we die. This is our bodies, that's what they're meant to do. We're meant to breathe, we are meant to drink water, we're meant to eat food, and we're meant to move. Look how quickly the body will start breaking down without movement. So I tell people, this is a need, this is a must. This has to happen. So, I just summarized that. So, yes, exercise is put on my list of physiologic needs. So, now I'm going to get into instruction. This is more than just a information that I'm giving you. I actually want to give you training on how to do this. And I've been doing this for a couple of years now in my clinics, and the results that I've gotten since I've been doing this are significantly better than they were before. Very noticeable. I have had multiple patients who've come to me. They tell me, I've been seeing psychiatrists for decades. I'm horribly depressed. I feel like dying constantly. And I've done this with them, and over a period of months, I've had them say, I don't really feel like I need to come back anymore. I feel okay. That's happened dozens and dozens of times. Okay? So, is this going to work with everybody? Of course not. And I want to recognize, too, that depression is very complicated. It can be caused by so many things. And we're just touching the tip of the iceberg with this. Like we're saying, we're just trying to find something better than what we're doing. And this will not fix everyone. It cannot fix everyone, but it's a place to start. So the first thing you do is you screen for depression. And there's lots of ways to do this. I won't go into it. But I want you to look out for a couple things, just to be careful, because I've seen other people do this. They'll screen for depression, and the person says, I'm depressed, and they say, great, let's get you on an SSRI. And they get them on an SSRI, and they have bipolar disorder. And then they have a manic episode, and then they're in the hospital. So if you give an SSRI to somebody with bipolar disorder, it will trigger manic episode, probably. So make sure when you're screening for depression, you say, have you ever had a manic episode or a hypomanic episode? Just real quick, throw that in there. And if they say, yeah, I think I had one of those, or what the heck is that? Well, okay, let me just explain it real quickly. And then if they've had one, say, okay, before I put you on an SSRI, we need to talk about mood stabilizers. I'm going to try to refer you to a psychiatrist. Check about suicidality, check into psychosis. And you may, if it's more complex, more serious, you may need to refer them to a psychiatrist. Okay, so I just came up with a few things, of questions you could ask. So now they said yes to depression. We're not dealing with bipolar disorder. We're not dealing with psychosis. We have a pretty clear diagnosis of what's happening. And start going down the questions. And you go down the questions until you get something. And the reason why I'm saying this is not that this is going to automatically fix all of your problems. What I'm saying is that if I were to build a fire up here, right here, I would need certain things in order to build a fire. I would need fuel, I would need a spark, and I would need oxygen. And if I had really, really good oxygen and really, really good fuel, but no spark, I will not get a fire. It's contrary to the nature of building fires. If I have really, really good sparks and really good oxygen but no fuel, no fire, okay? So I explain to people that happiness is complicated. And there are certain things that are required for us to be happy. And one of those things are physiologic needs, like eating healthy and getting enough sleep. If you're getting 2 hours of sleep a night, and I'm giving you tons and tons of medications, you're probably still going to be depressed. It's not going to fix it. We've got to address the sleep. And that's why I'm asking these questions, is because it's complicated, but this is one of the pieces. Be it the fuel, the spark, or the oxygen, it's one of the pieces. So how much do you exercise, or do you exercise? What do your meals look like? That's a weird way of wording it. What do you have for your meals? What time do you fall asleep? When do you wake up? What's your sleep routine like? What do you do for your hobbies? Or who do you spend time with, and how often do you spend time with them? How is your self-esteem? Just a quick screen. That took a couple seconds to ask. And if one of them comes out and they say, well, I don't eat meals, I just have candy bars and Mountain Dew. Boom, there it is. We're missing the fuel. You know, if I miss a couple of meals, have you ever heard the word hangry? I get depressed too, and anxious. Goodness gracious, I have children. I mentioned I have 7 children, which is probably too many. But you have a little child, and the child wakes you up a few nights in a row, and you miss a couple days of good sleep. Guess what happens? You start to lose your mind. You start to feel depressed and anxious. And some people live like this every day. I have a funny story I'll tell you later. Okay, so let's just go through. I'm just going to teach you how this is done. So first thing they say, all right, let's say you got a positive on the first one. You said, how often do you exercise? And they say, well, I don't exercise. Okay, so what I'm going to teach here for a second is selling. Salesman. You're like, whoa, Dr. Wadsworth, I am a physician. I am not a salesman. The reason why we need to learn how to do a little bit of sales is because we're trying to persuade people to make good choices. And if we know how to sell it, it's going to make us a better physician. And I know this might be something that you don't want to add on to your car, but it's a helpful thing to have on your car. If you can be persuasive, it really helps your patient make better choices. And this is whether it's trying to tell them to take their diabetes medication, whether it's trying to persuade them to quit smoking, whether it's trying to persuade them to exercise, whatever it is. So stick and carrot, that's what we call this, okay? So there's 2 avenues you come at with sales. There's the stick, which is like trying to get the rabbit to go forward by hitting it, and then there's or shaking the stick at it, and then there's the carrot where we lure it. So there's the good and the bad, okay? So this is kind of like psychoeducation, cognitive behavioral therapy. Stick. So this is something you could say. Person says, I don't exercise. You say, I bring this up because there are some really alarming studies coming out. Some data I have been exposed to indicates that failing to exercise can be one of the most detrimental or harmful things that you can do for your health. It can increase your risk of not only depression, anxiety, but also for stroke, heart attack, cancer, dementia, and many other things. That's a stick. Okay, ooh, that didn't feel good. I don't like that. It may be impossible for you to be happy if you're not exercising, or at least not as happy as you could be. Okay, what about the carrot? Let's get on. That didn't feel good. We'll do something that feels good. Carrot. Other studies are showing that even just a little bit of exercise a few times a week can dramatically improve happiness and feelings of calmness, improve sexual drive and function, and can protect you from a long list of illnesses. It can literally save your life. After looking at this new data, my main goal in visits is to help my patients to exercise because it can transform the quality of their life. Okay, there's the carrot. Now that sounds alluring. That sounds kind of nice. Some of you are probably thinking, Dr. Wadsworth, I've tried this. It doesn't work. All right, well, that's what I'm getting to the next part. Some of you have heard of motivational interviewing. Have anybody heard of that? Yeah, it is scientifically proven. It's shown to be effective. Now, does it work every time? Of course not. Nothing works every time. None of our meds work every time. So if you feel like I did it, it didn't work, well, now there's anything else work every time. But it does work frequently. So in motivational interviewing, there's something called change talk, and there's something called sustain talk. And it's really important to understand this, because if you don't, you could literally unwittingly persuade your patient to do bad things. You can entrench them into their smoking. You can entrench them into not taking their diabetes medication. You can entrench them into not exercising and making bad health choices if you don't understand this concept. And this has been demonstrated to be effective. So here's the best way I can summarize this is if you say something, if I get the patient to say something, they're more likely to do it than if I say something. That's kind of what it's about. And if I get them to say enough things about why they should change and they're going to change and they should change, the probability of them changing becomes higher. The more change talk that I can elicit in a conversation, the more likely they are to change. So if I have a 15-minute conversation with somebody and that whole time I'm eliciting sustained talk, they're not going to change. That's a waste of time. If it's not as a waste, it's actually worse than a waste of time. You just entrench them in whatever behavior. So it's very important in the 15 minutes that you have with the patient to be as careful as you can about what you say and what you ask and how you say it and how you ask it. And this might seem like very small things, but they are demonstrated in studies to have profound effects on people's behavior. So I'll give you an example of sustained talk. So if you say to somebody, why don't you exercise? What are they going to say? They're going to tell you why they don't exercise. Guess what that is? That's sustained talk. Well, I don't exercise because I've got all these kids and I'm tired all the time and my job has me working. I come home, I'm exhausted. And the last thing I want to do is go in and exercise because I don't have time for that. Nobody has time for that. And congratulations. Now they're definitely not going to exercise. Don't ask that, okay? Or don't ask anything that you predict might generate sustained talk. You have to pre-think your visit ahead of time and think about what things could I say that might elicit change talk in the 15 minutes that I have with this patient, because their health and their happiness depend upon it. And this is a skill, and it's actually really hard at first. So it's okay to work on this. So instead, you might say something like, and I'm not the best at this, I threw this together, but you have been feeling depressed for a long time, haven't you? How long have you been feeling depressed? I've been depressed for years, doctor. From 1 to 10, how important is it to you to stop feeling this way? 10 being very, very important and 1 being not important at all. It's an 8 or it's a 10. It's so important to me. Okay. So you're saying it's really, really important to you. It's going to be impossible, very likely, for you to get any better unless we make some changes in your life. We can start with really small changes. Really small. I'll give you an example. The other day, I had a patient. We made some goals. She came back, didn't do a single one of them. She says, I'm too depressed. I said, okay, we made goals that were too big. Let's adjust them. Do you think you could exercise for 30 seconds a day? Do you think you could do 30 seconds? Yeah, I think I could do that. Are you sure? Because I don't want to have a goal that's too big. Yes, I could do 30 seconds. Okay, do you think you could do it once a day? Twice a day or more? What do you think? I think I could do it 3 times a day. Okay, we are going to get you out of bed, and I'm going to get you to move your body for 30 seconds, 3 times a day, and I want to see you in 2 weeks. That's your goal, okay? Sometimes it's small like that. Sometimes that's all they can do. It's hard to understand depression. It's very difficult sometimes to do anything at all when you're very depressed. So set small goals or big goals, whatever they're ready for, and you elicit this change talk. And then you give them options. What kind of exercise do you think you would do if you were to do it? Well, I think I could take a walk. Okay, perfect. What time of day would you do it? In the morning? During a break? Afternoon? I think I could do it in the morning. Okay, perfect. So our goal is we are going to do 30 seconds of walking in the morning at this time every day. Now, usually it's more than 30 seconds for most patients, but that was a particular case. Okay, so does everybody understand how this works? So that conversation there, that's all the dialogue. Do you suffer from depression? Yes, I suffer from depression. How often do you exercise? I don't really exercise, blah, 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 blah. That whole conversation, I time myself saying that because I think, Dr. Wadsworth, I don't have time to do this. This is another thing you're trying to wedge in there with the time I already don't have. This whole thing, timed, took 1 minute and 24 seconds. Now, I was explaining it, so it took a lot longer earlier, but if I just record that conversation, I recorded a second time. Second time took 1 minute and 23 seconds, and I wasn't going, blah, 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 as fast as I could. I just talked normal speed, okay? Even if it takes you twice as long as that, we're still only looking about 3 minutes. This is one of those small changes that you can make to your automobile to make it just a little bit better. And the cool thing about it is you don't have to be a psychiatrist to do this. This applies to just about every field, except for, like I said, pathology and radiology. You guys will sit out on this one. But everybody else, this applies. Now, we're nearly over on time. I went through several of these, and I demonstrated the same pattern: the carrot, the stick, the motivational interviewing, eliciting change talk, avoiding sustained talk. I went through it on all these. The one I wanted to tell that I thought was funny was the sleep routine. I had a patient just the other day, came to me. They said, I can't sleep, I've got terrible insomnia, I really need you to give me some Xanax so I can sleep. And I'm like, yeah, that's probably not gonna happen. So, but I thought, well, maybe I'll just give him some trazodone or whatever. And no, I gotta ask the questions. I said, well, tell me about your sleep routine. And he tells me this: I have a caffeinated beverage around 9 p.m., it's like a Red Bull or something like that. And then he plays video games until 1, and then he lays in bed unable to sleep until 4 a.m. Okay? He doesn't need a pill, okay? He doesn't need a pill. He needs to change his behaviors. And that's what we did. And guess what? He doesn't have insomnia anymore because I got him to change. I did this, okay? And then I did this, and now he sleeps great. It's amazing what not drinking a Red Bull at 9 p.m. will do, okay? All right. In the last bit of time that we have here, that was my alarm saying we're out of time, so. I want to end with one last message, and that is hope. When people are depressed, it does something really bizarre to their mind that we don't fully understand. But they tell themselves a lot of things that are just not true. Things like, no one would really miss me if I ended myself. Everybody would be better off if I was just gone. I'm going to feel this way forever, and nothing's ever going to change. These kinds of things. And I had a patient that I made a mistake on about a year ago. He was a young father and well-loved in the community. And he got depressed for the first time in his life. Never been depressed before, didn't understand it. And I went through all the things I go through, and I couldn't really identify any reason why. So I said, well, let's try a medication. So I put him on a medication. And he came back, and it didn't work, so we increased the dose. And I didn't think a whole lot about it. And then I got a message that he had killed himself. And I've rethought about what I would do differently after that happened. Because I do a lot of work with kids whose parents have killed themselves. That's a whole generation of trauma that just got created there. And the one piece I realized I missed with him is hope. And I would really hope that you don't miss this with patients. If someone comes in and they say, I'm really depressed, and you start in with things, take a moment to stop and say, hey, look, I know this is really, really hard right now. And you feel awful, and you feel like you're never going to get better. But there's a lot of things that we can do to help you get better. Don't give up, please. Your family will miss you. You are important. You're a good person, and the world needs every good person that we can have. We don't want to lose a single one. So please, please stay in there, hang in. There's things we can do. If this doesn't work, we can try transmagnetic stimulation. We can try ECT. We can try esketamine. We can try a lot of things. We're not going to give up. We're going to find a solution. We're just at the beginning of this. This might take a little while, but don't give up hope. I am thankful for this opportunity that I've had to speak to you today. I'm honored. This is a very important subject. I'm very thankful that the Orear Institute is taking on the mental health crisis that we're facing. It is a crisis, and I hope that all of us together can make our 15 minutes that we have a little bit better to try and fight against this. And it'll take all of us. Little changes. Thank you so much.
All right. This is a book someone is kind of recommending, I guess. Have you read the book called The Anxious Generation by psychologist Jonathan Haidt? And because it discusses these 4 or 5 principles, especially with regard to children. No cell phones before age 16, no social media, go to a cell phone-free school, more free play, lots of connections, including adult.
Okay. Can I talk about that for a second?
Yeah.
So, I mentioned earlier, we're psychiatrists, we're supposed to have all the answers. Why are the kids getting so stinking depressed? And there are studies that are coming out, feel free to use your AI to look this up, indicating that it's related to social media, partially at least. The recommendations are coming out with, there's a lot of theories as to why this is, but they're saying, it might be a really good idea for you to restrict social media till they're 18. The average amount of time that a teenager is spending on screens daily is about 9 hours a day. Can you believe that? And this, I confirm this with my patients. I work with a lot of kids. And I said, how many hours do you think you spend on, and usually it's higher than that. And what they do for the most part is they will get on social media, TikTok or YouTube Shorts or something, and they'll just flip like this. And they'll do this for hours and hours and hours and hours. And one of the theories is that there's this dopamine release every time there's novelty in something. I mean, this is the most exciting things you can imagine. This unicorn did a backflip off of a gecko into a, it's like, whoa, and then the kids go to school and they're expected to sit and listen to a teacher after doing that all morning. Like, yeah, right, and then they stop and they're like, wow, everything is really boring in life. Like nothing's beautiful. The sky's not beautiful. The trees aren't beautiful. I guess I'll look at my phone again. And it's almost like heroin. And you take the phone away and they have pseudo seizures, It's scary. Really is scary. I've had kids attack their mother with knives and stuff. It's scary.
Yeah. And it's much harder to retrofit that than if you make the rules up front.
Oh, yes.
No dinner time phone, no phone after bed.
Taking away the heroin.
Taking away later is hard.
Yeah.
Yeah.